our followers are always looking for innovative therapies in the world of integrative cancer, and you clearly are that.
Yeah,
But your journey here is not a straightforward one, right? So
no,
can you kind of tell the listeners kind of
sure,
what your journey's been?
sure, yeah. Well, for me, one of the things was that, of course, my grandmother had died of breast cancer when I was young, which made me want to get into cancer. I thought that I was going to be a medical oncologist. And when I did research in college, we were doing stuff where we were injecting viruses into tumors, and it was working really well. And then when they would do the clinical trials in humans, they would give it intravenous. And I said, well, it didn't work. And I said, but we injected the mice, but we didn't inject it into the tumors in the humans. And oh no, it's too difficult. You can't do that. And so we were fortunate at LSU. We had these radiology, classes early, our first and second year. And I remember there was the first time that they did a lecture on interventional radiology, and the guy that was giving the talk was talking about how they were putting needles in all these locations for doing biopsies. I was like, wait a minute. I was like, if they can do that, then we can inject these drugs into tumors.
Welcome to the Practicing with Dr. Nathan Goodyear podcast. I'm the medical director at Brio-Medical in Scottsdale, Arizona. I am both a conventionally trained and licensed medical doctor as well as a licensed medical homeopathic doctor. This podcast is your resource for a scientific-based discussion of all things cancer and beyond from a natural, holistic, and integrative perspective. It's time to teach the body how to heal. So here we go. In the hole in the ground, there lived a hobbit. Dr. Goodyear with Practicing with Dr. Nathan Goodyear podcast. You may be going, what in the world are you doing quoting The Hobbit? Well, it's because The Hobbit is The Hobbit there and back again. And I have with me a colleague, an innovator, and actually a fellow graduate from LSU Health Science Center in Shreveport, the year 2000. Jason Willliams is, I think, one of the biggest innovators in immunotherapy in the world. And if you know anything about cancer, have researched cancer, you've probably seen his book, Immunotherapy, A Revolution. And I haven't had a chance to read it. He just gave it to me. So I'm not going to be one of those ones that, says, oh, I've read your book and I love it. I haven't yet, but I'm going to. But I know lots of patients that have read it and know about Jason Willliams. So because we were medical students together again, I thought The Hobbit, because I'm kind of a Hobbit freak, I thought it was a great way to bring in this concept, because immunotherapy and Hobbit have nothing in concert together, but yet it's the there and back again, because you and I were there 1996, August. We were there when we graduated May 2000. And then what brought us back together was immunotherapy.
Yeah.
So Jason, Dr. Willliams, it is
Nathan,
so awesome to see you.
Good to see you too. Gosh,
yeah.
yeah. It's amazing. Sat next to each other in class. And,
No.
And The Hobbit comes back from Dr. Clausen.
Oh
Remember
my
Dr.
gosh.
Clausen, Bilbo Baggins, and
That's right.
Yeah, he also used to always include that in all of his lectures. In anatomy.
I forgot that.
Yes.
So you just mentioned that.
Yes.
I forgot Dr. Clausen's name.
Yeah.
He was actually a great professor.
Great professor.
Great
yes,
professor. That's what was so weird about this is not only did we go to medical school together, we were basically kind of right there in the same group. We sat next to each other. I mean, the first 2 years we were pretty much in class all day, every day. And so we, of course, well, first of all, I guess, tell me your journey, because we took different journeys, different paths, but in some ways we're kind of back at the same point. So, our followers are always looking for innovative therapies in the world of integrative cancer, and you clearly are that.
Yeah,
but your journey here is not a straightforward one, right?
No.
So can you kind of tell the listeners kind of
Sure.
what your journey's been?
Sure, yeah. Well, for me, one of the things was that, of course, my grandmother had died of breast cancer when I was young, which made me want to get into cancer. I thought that I was going to be a medical oncologist. And when I did research in college, we were doing this where we were injecting viruses into tumors, and it was working really well. And then when they would do the clinical trials in humans, they would give it intravenous. And I said, well, it didn't work. And I said, but we injected the mice, but we didn't inject it into the tumors in the humans. And they're, oh no, it's too difficult. You can't do that. And so we were fortunate at LSU. We had these radiology, classes early, our first and second year. And I remember there was the first time that they did a lecture on interventional radiology, and the guy that was giving the talk was talking about how they're putting needles in all these locations for doing biopsies. Like, wait a minute. I was like, if they can do that, then we can inject these drugs into tumors. And so I said, you know what? I'm not going to be a medical oncologist. I'm going to be a radiologist. and that's, I went into radiology, but with the idea of treating cancer. That was what I really wanted to do. And so, and then later learned about a fellow LSU alum who was doing a lot of innovative work in ablation, where you stick needles into tumors and you use radio frequency or other things to kill and heat up the tumor and destroy it. Cryoablation. Patrick Sewell.
Okay.
Patrick Sewell. He was ahead of us. He did his residency there in medical school at LSU, and then he finished probably 2 or 3. Well, he finished his residency at 2 or 3 years ahead of us. He was doing a fellowship. Yeah. And so everybody at LSU there knew who he was. And when I told him, I was like, I'm interested in this cancer stuff, the radiologist at LSU said, you need to look up this guy, Patrick Sewell. So he was at the University of Mississippi. So I got our senior year, when we could go and travel to other places, I went and did several months there with him, and saw, sticking needles into tumors and destroying. I was like, this is amazing.
Was that in Jackson?
In Jackson.
Okay, because I did a month rotation in Jackson too.
In OBGYN?
Yeah. We could have been there
at the same time.
Yeah.
I went there right off the bat, like the first start of the fourth year. But so that really influenced me a lot. And then starting try to take the things that we were doing research-wise. I'm like, now we can put it all together. And when I ended up going to my radiology residency, which is at the University of South Alabama, the chairman there, those were guys that started CT-guided procedures, so it was really kind of a nice fit. They let me do a lot of what I wanted to do, and I said, hey, there's this ablation stuff. I said, we could stick needles in tumors and destroy it. And they're like, well, you want to do it, great, if you can work it out. And so I contacted the companies. I started a website. I started doing basically blogs back then in 2001, 2002, and started getting patients and started treating people, and corresponded a lot with Dr. Sewell in Mississippi. Yeah. But the thing that I saw was that I wanted to try to help everybody. So a lot of the cases that everybody else would turn away, I was like, oh, I'm going to take those on and we'll try to help them. And I saw them do better than I ever expected that they would do, and a lot of them didn't have options for chemotherapies. And so I thought there's something with the ablation that's doing something, stimulating the immune system, making the patients better without even having to give them medications. And that got me really, really interested. And then I had to figure out, what can we do to make this happen all the time? Because some of the cases, the patients were getting amazing responses, and so there's got to be a way we can make it better. And that's led me into that journey, put me into with the immunotherapy. Ultimately, that was the things that we figured out. You do the ablations, you do the immunotherapy together. Really powerful. I mean, it's amazing that you can inject a much lower dose of the drug in the tumor. I mean, sometimes fraction, less than 10% of a systemic dose, and put in the tumor, and it works better than the systemic immunotherapy. And the others, the combinations, because you can never give 8, 9, 10 immunotherapy drugs systemically. The patients would have terrible autoimmune issues. But in the tumor, very forgiving. I mean, you can do a lot. I mean, we sometimes do 14 agents.
Wow.
The other, of course, also is you want to test tumor killing. You want to inject an agent, see if it looks like it's killing the tumor. But it's just it's a nice area to see in the patient how things are working. And so that's why I really got in that, and then just got fully into where essentially, like having a PhD in immunology, studied so much immunology, and got interested in all the other aspects, and also wanted to take it to another level. We're using like the off-label drugs to enhance immune response, supplements, manipulating the microbiome, all the things that are, unfortunately, not done with a lot of the standard immunology or immunotherapy patients. Those patients, they get their Opdivo, they get their Keytruda, but they're not getting anything to maximize it. It's one thing last year that was a little bit shocking to me was there was an article that came out about acetaminophen. I don't know if you saw this.
Oh, Tylenol? No.
Tylenol completely stops the immunotherapy from working. 100%.
Okay, now that makes sense. I mean, counter that, aspirin is a non-steroidal
That's right.
anti-inflammatory.
Which
that
enhances.
That's right, that enhances it.
Exactly.
So I always tell patients, don't take Tylenol.
Yes.
You need to take anything. Well, in fact, I use aspirin.
Right.
But, celecoxib is a COX-2 inhibitor.
Those are all fine.
Yeah, these are great. But so aspirin and Tylenol, both over the counter. One is beneficial, one's detrimental.
Terrible. And the other thing is that lots of immunotherapy patients are pre-medicated with Tylenol. So you're messing it up right there. Wow. They're advised if they get fevers, which sometimes they do with immunotherapy, take Tylenol. And I didn't realize this, but first, so I saw the article. It's actually a friend of mine, a guy that's become a friend of mine. He's in France. His name's Orléans Mahabel. He's a medical oncologist, has a PhD in immunology, and is big into intratumoral immunotherapy. He was sort of the one behind what we call the Stanford cancer vaccine, which was using OX40 with CPG with Yervoy. I mean, he did it with Yervoy. Later, Ronald Levy, who was his professor, did it with just OX40 and CPG. But they got 100% cure in these mice, and so that was his work. And he's a real big intratumoral guy, but somehow he ended up doing this article, mainly with his graduate students, I'm sure. But they went and looked at patients who took Tylenol and what was their response. So they decided they picked renal cell carcinoma. They looked at about 240 patients, and they said any patient who's taken Tylenol, what was their response rate? Zero.
So it completely shut it down.
Completely shut it down. So then they said, you know what, we're not even gonna trust that the patients are telling us that they're taking Tylenol. We're gonna go back and take all their blood samples that they had saved and measure Tylenol levels in everybody.
Wow.
And the people who didn't say they were taking Tylenol were non-responders as well. And turns out in 2015, the World Health Organization made a recommendation: if you receive a vaccine, you should not take Tylenol within 2 weeks. And they were finding it was making the vaccines not work. Right. And so this group said, well, if it makes the vaccines not work, what does it do to cancer immunotherapy? And so it's when I look at it, I don't know if you call these like the three horsemen, but you look at the things that are bad for immunotherapy, and Tylenol, steroids. Obviously there are certain situations, but you try to avoid them. When you look now at like patients getting chemotherapy plus immunotherapy, you have to take the steroids out. They give them dexamethasone mainly for nausea, but if you give them that, you're going to reduce the chance the immunotherapy works. And the other being antibiotics. Right. And so obviously some patients need to take antibiotics, but we know you mess up the microbiome, the patients are less likely to respond. The only ways we know around it are two things. One is using a bacteria called Clostridium butyricum, which you can buy from two sources. One is from Japan, the other is in the US. Was used to mainly treat diarrhea or to do fecal transplant. And of course now there is an FDA approved fecal transplant, Rebiota, which is an option, but it's hard to get, it's expensive. A lot of the patients were resorting to doing their own fecal transplants. Right. Meaning, identify a trusted person, because usually they weren't going to be able to do all the testing. They were doing it sort of clandestine on their own. So usually a spouse or a child or somebody that was close to them.
Yeah, because I believe I think it was there was a study where they looked at ulcerative colitis. It was way back in the beginning with fecal transplant. And they actually had a subset of the patient population. They had I can't remember the exact data, but it just came to my mind when we were talking, that they had significant remission in the ulcerative colitis. Definitely. But then they had a few of the patients that all of a sudden became obese. And what they found is they went back to the donors. And they found that the donors of which those patients that transitioned from normal weight to obese morbidly, they came from obese individuals. And so now people focus, well, that's metabolism. What's that got to do with anything? What both of the what you're saying and what that article was saying is it really points towards the not just the gut but the bacterial population,
Right.
microbiome, as really being a kind of a central figure
Right.
to the entire metabolism of the body as a whole. And metabolism is not just weight, it's how things function.
Yeah.
And so you can put immune system in that as well.
Sure.
But I mean, so these kind of tie together.
Yeah, and even now they're looking at longevity. You know,
Yeah.
bacteria like Akkermansia, which is
Oh, yeah.
associated with an improved immune response, very important for immunotherapy. And now that you can actually take as a supplement. Previously, it wasn't
I think
available.
there's one source.
There's
right?
one source.
Yeah.
Yes.
Yeah. I know because
One
I
source.
got that source from him.
Yes. Yeah. I mean, I didn't. I got it from a patient. You know, because it was in my book saying, well, there's Akkermansia, but how do you increase it?
Yeah.
You know, polyphenols, cranberry extract, camu,
Yeah.
that type of stuff. But there was no way to directly do it. And then this company came out with it, and then it was interesting that a patient told me, hey, there's this one online, and I looked at it, and sure enough, it was there, and a lot of the people who were taking it were people that read my book but then found that
wow.
source. And so the company actually ended up asking me to speak one time at one of their meetings. It was online, and I go and I'm speaking, and the other person on there said, hey, I'm taking it, or I gave it to my father who responded to immunotherapy because I read that guy's book.
Oh, wow. Wow.
So it was interesting that what a coincidence. But yeah, that helps a lot, because before, fecal transplant was the only thing you could do. If you didn't have Akkermansia, you were really in a bad situation. And
Yeah, and I want to come back to that gut issue in a second, because I think, you and I were talking last night over dinner and yesterday afternoon. We were talking about, I think future and the gut being really front and center with that.
Yeah.
But you touched on something a little bit earlier. First of all, I love how, you're not an oncologist,
right, yeah,
but your different perspective has really forced a different solution
yeah,
to a problem.
sure,
And I'll never forget when I was looking at going to do pelvic floor fellowship. I went out to a conference in San Francisco, and I was talking to one of the premier pelvic floor surgeons at the time. And as I told you last night, he was asking where I train. He said, you don't really need to do it unless you just want to do publication research. I said, oh, okay. He said, you have the skill sets, just go. But in that conference, there was a doc that got up there, and he was describing the pelvic floor anatomy.
mm-hmm.
And he was doing it almost like J.R. Tolkien wrote The Hobbit. It was artistry.
Right.
It was beautiful. There was beautiful drawings. And so he kind of went on for about 20, 30 minutes. And then he stopped and he said, and by the way, I just have a little caveat for you. I'm not a surgeon. I've never operated on a patient in my life.
Wow,
I'm family practice.
really? Oh wow.
He just had an interest in pelvic floor anatomy.
Sure.
He had a different perspective,
Yeah,
and he brought that different perspective to provide a beautiful solution in describing anatomy,
yeah,
but also drawing it that helped surgeons.
sure,
And so sometimes when you're, it's like you're sitting there looking at a problem over and over and over again, and it's just the way you're looking at it, and somebody just comes along and looks and goes, oh, and you're like, oh,
right,
my gosh, why didn't I see that? And that's how I see your journey.
sure,
It's similar to his, which obviously for me, pelvic floor surgeon, OBGYN, we both had different paths, but yet they brought us back to cancer, and it's through immunotherapy.
yeah,
That's what bridged us back together.
sure,
Because I had a patient that asked me, she said, I want to do cryosurgery. I said, well, I don't know that you get that done in the U.S.
yeah,
I said, check out Germany.
right,
And I said, but I don't know where to look.
yeah,
And so she then called me back and said, yeah, I found a great doc. I was like, where? She said, in Mexico.
yeah,
You were in Mexico City at the time. And SR is her initials. So if you're watching, and we were follow up afterwards. And I said, so when are you going to see him? She said, oh, I already went to see him.
yeah,
And the treatment went great.
yeah,
I said, oh, fantastic. Yeah. She said, yeah, there's one thing. I said, what's that? She said, he knows you. And I said, who is that? So I reviewed that with you
Yeah.
yesterday. She said, oh, Dr. Jason Williams. And I was
Yeah.
like, it was like one of those Hollywood moments where everything just kind of Hollywood moments comes right up on you. But so it was a mutual patient with cancer that actually reconnected us. But you mentioned something earlier about fever,
Yeah.
Tylenol.
Sure. Yeah.
And so when we look at the immune system, everybody knows when their immune system's active is when they have a fever.
Yeah.
I'm curious what your thoughts are on this. I kind of have an idea, I think. Is fever the enemy?
No, I don't think so at all. I think that, what I tell patients is that if you're comfortable,
Yeah.
then just, let it ride.
Yeah.
If you're uncomfortable, then take some ibuprofen.
Yeah.
But yeah, I mean, obviously the body's, doing that because it's trying to fight something and it's doing it for a reason. So we really probably shouldn't try to suppress it unless
Yeah.
it was dangerous.
Exactly.
Which generally it's not.
And,
So-
and I think that's something that may come across to people as being different, is that when the immune system is active,
Right.
that's a good thing.
Yeah.
I was doing some research here recently just because I'm a geek. Now, what was the title of that podcast?
Cancer Geeks.
We
should do that together. We should make it
Cancer
together.
Geeks.
We'll make that together.
Because I actually have, I'll tell people I'm kind of getting my nerd on. I'm getting my geek
Yeah.
on.
Yeah.
Just because you're probably like me, we just kind of go down these rabbit holes.
Yeah.
And so I went down this rabbit hole of spontaneous regression.
Yeah.
And, it's been described in the literature, going back, thousands of years. There's a Catholic priest who had what appears to be probably a sarcoma.
Right.
And he developed a superficial skin infection.
Yeah.
And he, quote unquote, was cured.
Sure.
So there's multiple documentations of this kind of spontaneous regression that occurs, but every one of them is through an infection or from an immune response.
Yeah. Just like Coley's toxin.
Exactly.
Yeah.
Well stated. And what William Coley did is he just looked back. In fact, in some of his early papers, he documents how he was just looking back at history.
Mm-hmm.
And he was just connecting dots.
Yeah.
And that's kind of what you've done.
Sure. Yeah.
You've just said, well, I want to connect these dots. This is interesting that this systemically doesn't work, but if I inject it, it does.
Yeah.
So I find that fascinating. But spontaneous regression, I think, tie into immunotherapy clearly because it is an immunotherapeutic response. But at the same time, there was a recent article that came out in 2020 that said, we're not seeing a lot of spontaneous regressions anymore.
Mm-hmm.
And I was like, I wonder if it's because of what we're doing with our approach to treatment.
That's
Are
right.
we subverting the immune system?
Sure.
And
Yeah.
that's why, and from a generational standpoint, transgenerationally, we're seeing immune systems that are less equipped to respond.
That's true. Yeah. 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 Obviously, and now anytime even a hint of a potential infection, the patient gets antibiotics, even though a lot of times they don't even need it.
Right.
But yeah, and the work of Coley, obviously led to some of the newer immunotherapy agents with like the one CPG. CPG is toll-like receptor agonist.
Yeah. Oh yeah.
That was carried on by Lloyd Old, who worked with Coley's daughter, and they discovered that I think in the 70s.
I actually quoted him in the timeline of immunotherapy that we recorded before you showed up.
Okay, yeah.
Yeah, because I was told you before, I was going through important milestones in immunotherapy, and Old is in there.
That's obviously he did a lot of work and in the TLR, particularly CPG, the innate immune response. I mean, it's the thing is that one thing, the immune system needs to know there's a problem. If the immune system doesn't know there's a problem, then, well, there's a real problem because it doesn't know what to attack. And these, stimulators of the innate immune system, the immune system that doesn't know what it's supposed to attack but knows there's something going on, it goes and says, okay, hey, come here and check this out. We think something's a problem. That's what the innate immune system, that's what those TLR agonists like CPG do. They come in and say, oh yeah, we should attack this or we shouldn't. And that's what we do is we first bring in the immune cells, and then we use other drugs to say, yeah, it's correct. You're supposed to come here and attack this. And so, but it's why you have to kind of do some things in a sequence where you start with a priming to hit the innate, and then you start doing like stimulation. So, certain agents that will stimulate the activated T cells or other immune cells that are there. And then the checkpoint phase where the immune system's getting shut down, but then now you go heavy to try to stop that.
Yeah.
So
Yeah, there's two things I don't want to forget here. But one is precision therapy stacking. That's a phrase I like to use. And you're talking about the therapy stacking because people look at cancer and the way the mindset is with cancer, it's sequential.
Yeah.
Okay. Neoadjuvant chemo, surgery, then radiation. It's a very sequential process, as if cancer is going, oh, now the chemo's coming, I got to do that.
Right.
So it's a dynamic process. So there's that, but then it's connecting the gut to immune dysfunction.
Yeah.
Talking about the innate immunity. So I think the point you touched on there, Jason, was brilliant about it's the combining of the therapies.
Yeah.
And you've recognized that, I've recognized that, but again, we bring different experiences to that same point. But you're actually implementing that in what you're doing in more of a focal, direct approach to the tumor cells, right? The cancer.
Yeah. And you look back on things. I mean, particularly I always think about, and obviously like when we were learning and training at the time of like HIV being bad, and sort of we went through where
that was our days.
Treatment, right?
Yeah.
But at first, when we were at LSU, everybody was dying, and what did they do? They would give the patient one drug, and then when that failed after about a year, it was the second drug, and when that failed after a year, it was the third drug.
Right.
Then they realized, but it was really by a mistake, I believe. What I understood was that when they were doing studies, they were supposed to give like placebos and in certain drugs, but they made a mistake and they actually gave people all three of the drugs at once. And those were the ones that did well. And that led to the triple therapy for HIV. But yet that seems so obvious. You would think that's obvious. Just use all the drugs. But for some reason, in oncology, they are getting better. I mean, you are starting to see now chemo plus immunotherapy, but generally they're like, okay, let's give the patient cyclin-dependent kinase inhibitor. Okay, that failed. Okay, well now, let's do a PARP inhibitor. Let's do that, and it's like, but not stacking all the different ones together.
Yeah.
And so it just seemed obvious, but now clearly some of these drugs do have side effects, and so you start stacking them. That is the advantage of the intratumoral approach, because
and your lower dose,
you don't have those type of issues. And so and again, the other thing is, it's nice when you're attacking a tumor. We like to see what it does. Then also I look and see, what are the other tumors doing? I hit this one. Did that tumor, now is it changing? Okay, and then when we start seeing, this thing is really going, then we're just gonna start throwing that and heating it up.
That's a beautiful transition, because one of the things I wanted to touch you on is, you're familiar with the abscopal effect.
Sure, yeah.
And this is a concept that I think was it originally born out of radiation, where you radiate a tumor and it induces a systemic effect.
Yes. Yeah.
This has been described in other arenas as well.
Yes.
So with your therapy, now we're not talking about radiation here, but this has been shown in hyperthermia, but you're talking about ablative techniques, which you could say hyperthermia is that as well, in part. Are you seeing systemic effects? You're kind of alluding to that. Are you seeing systemic effects from a direct intratumoral therapy like what you're talking about?
Definitely. And that's mainly what we're doing, because of course we're particularly doing a lot of advanced cases. So for us, it wouldn't be really helpful if we're only treating the one tumor and we get a response there, but we don't get a response anywhere else. But it's amazing. You treat those one areas and you see the response. I mean, complete responses everywhere. The other thing we're always trying to figure out is, okay, do we keep treating this one tumor where we're doing really well here, or do we split out? Do we do others? Those are all the things we're still trying to sort out. I think it's different in different cancers. A lot of times we find if we hit two spots, that's better, probably because we're getting more diverse antigens.
Yeah, heterogeneity. You're really tackling that on multiple fronts.
Yeah.
It's really interesting, because when you look back at the initial push in immunotherapy, they were using inoculation, smallpox, and these kind of things. And so, in fact, I was highlighting, I think she was a Princess of Wales. She volunteered up 6 people that were in prison to get inoculated.
Yeah.
And then they they got over the infection, and they sent them out into the general public.
Yeah.
And of course there was a massive infection ongoing in the community, and none of them got sick. Right. So they said, okay, fine, you have your freedom.
Yeah.
but that shows you the power of the immune system.
Mm-hmm.
And so with your therapeutic approach intratumorally, with all the immunotherapeutics and all the great therapies that you're providing at one time, you're really tapping into that, not just a short term,
Right.
not just a focus issue, but a widespread systemic long-term duration effect.
That's right.
But you're not creating anything new, you're just taking advantage of what's there.
Right. Right.
The immune system.
Yeah.
And I think that's fascinating.
Yeah, a lot, obviously there's a lot of interest right now, like in CAR T therapy, which, looks good, but CAR T is one dimensional. I mean, it's one antigen, and we're creating that immune response in the tumor. So we have the diversity of antigens. We have the other thing, CAR T, obviously very expensive. It's very difficult to do. And this is a much better process by essentially making that vaccine inside the body.
Yeah.
So.
Yeah. And again, I've said this before, best answer to cancer is don't get it.
That's true.
Nobody wants it. Bad things happen to good people all the time.
Mm-hmm.
But beyond that, the best answer to cancer is the immune system, because the immune system is the body's defenses against all enemies, foreign and domestic. And you're just using that.
Yeah.
It's interesting you talked about, the lower dose.
Yeah.
And, it's really interesting. I'm an advocate for lower dose chemo,
Sure.
metronomic chemo, 5-10%. And in fact, when you look, it's very similar to what you're describing. You're just doing it more, intratumorally, is that the lower the dose you go, the more immunomodulatory it becomes.
Yeah, that's true.
Stimulating natural killer cells, downregulating Treg cells, not wiping the innate immunity out,
Yeah. Yeah.
but actually stimulating it, which really fits exactly in what you're describing.
Yeah. Yeah.
And so you believe that the abscopal effect is real.
Oh, it's real. It's definitely real.
Yeah. I do too. But I just
seen it many times. Yeah, thankfully. Yeah, it's it's as we say, treat locally, act globally.
Oh, I like that.
So,
that's very good.
Yeah.
The other thing I wanted to touch on, because your history is you innovate in a lot of areas.
Yeah, that's true. Yeah.
And you mentioned this to me when we talked yesterday about you're innovating in another area. And I'd love to talk to you off script about that as well, the AI and that kind of stuff.
Sure.
But the gut.
Yeah.
Because, we know that in many ways the gut is the key to immune function. Yes. And we know that, the bacteria, the gut microbiome actually helps to control Th1, Th2 balance, which is critical between, talk about autoimmunity and all these different things. I'd love to hear your take on, because you've already touched on it before and we've talked about it. I'd love to hear your take on the importance of the gut to what you do.
Sure.
But then where you think the importance of the gut is going to all therapies in and around immunotherapy as it relates to cancer.
Yeah. Well, one thing, of course, is that, testing of the microbiome, looking at certain bacteria. There's been several groups that have done studies looking at, and it seems like each one comes up with a different bacteria. One group says, okay, well, we looked in Bifido brevi, Bifido longum. Another group's like Akkermansia.
Yeah.
Another is Fecalbacterium prosnazi. And so another one, Clostridium butyricum. You have these different ones that they say, oh, this one seems to be the key. And then of course, there's the interplay between it. I mean, some, depending on what all sort of combinations that you have. But we know that, for a lot of the immunotherapies to work, you need to have some of these bacteria present. Mm-hmm. The one thing that's been sort of classically shown is high fiber diet.
Yeah.
A diverse microbiome, the more diversity, the better the response. Interesting enough, taking general probiotics seem to be negative, seem to be hurtful because you're reducing your diversity. You're, a lot of times patients say, hey, but this has like 10 billion, it's 10 billion, but 10 billion of the same. Your microbiome is like a rainforest and you're planting corn when you do that. Yep. So you want to keep that diversity, which obviously the high fiber helps. Then there are the certain key bacteria. I think Akkermansia being probably one of the top.
That's big.
Now, obviously, as we said, there is a form that you can take. Also, you can increase it. That's the other thing. It's one thing of having it, but the other thing is feeding it too, because you can have them, but you're not feeding them. If you're not feeding them appropriately, they don't do what you need them to do.
And it's interesting you mentioned the fiber and the probiotics, because was actually just getting my geek on this morning, always trying to keep up to date on the data and the research. I was reading an article. They were looking at people that took probiotics
Yeah.
and those that basically ate probiotics through diet,
Yeah.
fiber.
Right.
They found that those that had the high fiber diet did better
Sure.
than
Yeah.
those taking the targeted probiotics.
Yeah.
Now, they weren't looking at it necessarily to say, well, let's give these probiotics to try to augment radiation, try to augment chemo, to try to augment immunotherapy.
Right.
They were just trying to compare the two.
Yeah.
So, I think you're probably a lot like me in this, Jason, that, definitely we can use targeted probiotics.
Sure.
And they can have their purpose. But the better answer and the connection of this to the immune system is probably diet.
Yeah. Yeah, most of the time I tell my patients, the Akkermansia, the Clostridium, take it, but only take it like 2-3 times a week. Just have it in your system, but we don't want to like overwhelm. We just want to make sure that it's kind of present, and then you sort of, nurture it with your diet. Things like camu. There's really some interesting studies going on with that. That's a fruit from the Amazon rainforest that looks kind of like a cherry.
Okay.
But you find it in the powder, you find it in the pills,
Yep.
and that functions a little bit like a fiber or like a prebiotic, a microfiber. Seems to really nourish a lot of these beneficial bacteria. There are some studies that are ongoing that look like that camu significantly boosts the response of patients on immunotherapy. So I think though, we're trying to manipulate the microbiome as an added treatment.
Yeah.
So that's where we're going. The other thing is looking at the interplay, because that's where, like with the AI stuff that we're looking at, we're looking to say, okay, if you have these genetic mutations in your tumor, your microbiome looks like this. Maybe your cytokine panel looks like this, your HLA is this, all these other things, then you need this, and this. And we're looking for the AI to predict that and tell us the things. And so it would include okay, this person, maybe this diet's better for them. This person, these off-label drugs, that's what they need. These supplements, and this type of immunotherapy.
Precision therapy stacking.
Yeah.
I mean, but so when we're talking about nutrition, people go, there's science to support that. It's like, and not only the science to support it, but the connection between the food we put in our mouth, the impact on the gut bacteria, the metabolites, and then the systemic effects that eventually aids or is a detriment to the immune system. So you think that the gut is critical to immunotherapy that you do.
Yeah.
And I do too.
I say it's the base foundation.
Okay.
I mean, it's kind of like if you don't have that, you can't build on top of it.
Yeah, and I was actually reading another study highlighting different dietary, looking at high animal protein versus vegan versus ketogenic, etc., and how these different bacterial populations were having different effects on the immune system.
Yeah.
So where do you think we're going with the gut immune system immunotherapy cancer? Where do you think the future's holding out there for us?
Yeah, I mean, so probably, you're going to see a lot more of this fecal transplant stuff now, particularly that there's an FDA, of course, the FDA approved ones for C. diff infection.
Right.
But we could use it off-label, but I think you're going to find these sort of off-the-shelf versions where you say, okay, if the person takes that, that's going to really repopulate their microbiome and be helpful, and I think you're going to start seeing people all around doing that, because a lot of people, I'm sure, have poor microbiomes, but
I'd say most Western countries do.
That's where of course, right now with supplementation you can boost it some, but I think that's going to end up being the easier answer. I mean, for us, what we do, we say, let's check your microbiome.
Yeah.
We look for the few things that we know. There's obviously a ton of stuff we just have no idea. But look and say, okay, do you have these key bacteria or you don't? If not, can we introduce them?
Right.
Do you have something really bad where we can't fix this with supplementation? You're going to need a fecal transplant. And the others, there's interesting ones like pancreatic cancer.
Mm-hmm.
Pancreatic cancer was seen to be associated with certain presence of bacteria.
Yeah.
And so the question was, in a pancreatic cancer patient, are you better to wipe out their microbiome, give them oral vanc, oral neomycin, oral antibiotic to just eliminate their microbiome and start fresh and give them a new one? And that's kind of where things...
It's following the path of that thinking, that logic is kind of a bone marrow
right Exactly, exactly. Same type of thing. Yeah, wipe out.
Interesting.
Say this microbiome is bad, and that's where I think the newer studies were so as we're talking about this and I was alluding to there was this previous study where they did immunotherapy, and the patients who failed, if they did a fecal transplant from patients who were good responders, that those patients would respond, and so everybody said, okay, that's a good answer. You get your responders and you donate. Obviously, it's a little more complicated, and the FDA makes it even more complicated because they don't quite allow those type of things to take place.
Bureaucracy always complicates.
Yeah, there's but then now with the Rebiota, this is from supposedly healthy donors. I don't know how they select their people. I don't know what their consistency is. The FDA, that's one thing with fecal transplants is that they're going to want to see consistency from, if you have this Rebiota today or in a year or in 2 years, they want to see it all the same. So I guess they found a way to do that. But
so we really need to know our crap, right?
We do. You do, exactly. You do on this. So it's interesting, but the now it looks like that they're showing that type of fecal transplant from healthy donors, healthy pooled donors, may be better than even the ones that are super responders.
Wow.
And so yeah, it's saying that this person, they have cancer, and that's what they were saying. The super donors had cancer.
Right.
So their microbiome was certainly better than the non-responders, but they still had cancer.
Wow.
Whereas these people don't have cancer, at least supposedly. And so that it does kind of make a lot of sense where if you give the person a healthy microbiome, maybe that would affect a lot.
Will we ever get to the point you think of designer fecal transplants?
Oh, definitely. I'm sure that will be the case. I'm sure that, and again, it's going to probably come down to the AI and looking, say this, you've got all this stuff, so you need these bacteria, you need this type of thing, and then there will be different ways they can, I'm sure, manipulate those concentrations or different bacteria. It's clearly going to be that way.
Yeah.
I don't know how long it'll take, but yeah, it will be there.
So really, your targeting of the tumor is really transitioning to a continued targeting of the tumor that moves systemically, but now you're targeting the gut and targeting everything else that you can to stack those therapies together.
Yeah, just like trying to create the, world-class athlete, giving them every advantage. It's not just the going to practice. It's doing all the other extra things that you need to do. You played football. I played football. For me, when I was kicking, football season was 365 days a year.
Oh, yeah.
I didn't take off. I kicked almost every day. Had to go to the gym. Had to, do stuff. I realized looking back, I didn't do enough. My father at the time told me, he said, you think you're doing a lot, but you're not doing enough. You could do more. Oh. And he was right. Mm-hmm. But he told me, he said, when you're, when you get like 40, which I passed already, unfortunately, but he said, you're going to look back and you're going to say, you know what, I could have done better. And that was true. Thankfully, though, I didn't become a professional football player, but so it's probably a good thing.
Yeah.
But yeah, with cancer treatment, you have to do all those things to take every advantage from the supplements, diet, exercise. Yeah. You got to try to get the microbiome. Yeah. It's not just the immunotherapy drugs. If you're only doing the immunotherapy drugs, it's like you're just going to practice. Don't ever expect to be in the Olympics or a professional athlete. So.
Yeah. I mean, I can't wrap that up better than what you said there, because you just created the perfect bow to wrap this up. But let me tell you this, neither one of us played professional football.
No.
You are in your calling.
Yeah.
You're in your element, and that's why, there and back again, thank you for patient SR for reconnecting us. Mm-hmm. Took a little bit of time for me to come down here, but this is why I wanted to come and see you south of the border. First of all, because we're classmates.
Yeah.
We're going to reconnect as friends.
Yeah.
We're colleagues.
Sure.
And you're just doing some amazing, innovative work. And so what I wanted to do is come down, and obviously we have patients that come to see you, and we will definitely send more that can take advantage of that. But I think the world needs to know about the innovation that you are doing as are others. And so, man, I'm super excited to reconnect with
I
you.
am too. Yeah.
Enjoyed meeting your wife and having
thank you.
dinner last night. My wife and I did. So I look forward to, maybe let's have some geek conversations, definitely.
Yeah.
Because, I approach things from a more natural, holistic, and integrative side. And you definitely are an integrative, innovative side.
Mm-hmm.
And I think there's a lot of, we were talking about artesunate last night.
Right. Yeah.
Vitamin C. There's lots of ways that these things can work together in concert.
Sure.
Really interested in cryo, hyperthermia. Is there any benefit to this kind of push-pull?
Right,
Sifri, Dr. Thomas Sifri talked about in a more metabolic perspective. Is there any benefit that? But just trying to expand the scope and the vision of what can be done out there, and just constantly innovated, just like you are.
Yeah.
So thank you for taking time out of your schedule, Jason.
I appreciate it, Nathan.
You are a friend. You
Yes.
are a colleague.
Yeah.
And I can't wait to do more work with you, man.
Yeah.
Okay.
I appreciate it. So great.
bet.
So great seeing you.
So this is Dr. Goodyear. We're going to be signing off for the Practicing with Dr. Nathan Goodyear podcast. We are down here. By the way, I didn't say this. We are in Cabo San Lucas, Mexico. Did I get that right, Andres? Did I pronounce it right? Okay, he's not going to say it because he's in the background. He's a little shy. But I encourage you to subscribe to the podcast. Share it with everybody that you think would benefit from the innovative work that Dr. Jason Willliams and we are at Brio doing. And the name of your clinic is Willliams
So
Cancer
Willliams
Institute.
Cancer Institute. Yes.
Yep.
Yeah.
And two, okay, check out this book. I'm sure you can find it online wherever you buy your books. I'm sure Amazon, etc. I'm not going to lie, I have not read it, but I am going to. It looks like an easy read here. Yes, without my glasses, but it looks like an easy read. Subscribe, share this with family members, everyone you think can benefit from this amazing, innovative knowledge that Dr. Jason Willliams was talking about and we discussed. So look forward to bringing more podcasts to you in the future. This is Dr. Goodyear signing off with Jason Willliams in Cabo San Lucas. For more information just like what we discussed today, I encourage you to follow us on YouTube as well as all of your favorite audio streaming platforms. And in there, we'll talk about all things related to healing, wellness, cancer, and much, much beyond, because it doesn't just apply to cancer. Our goal here is to turn to healing, restore health, and promote your wellness, whether that greatest obstacle to wellness being cancer or any other named disease. Our goal is your wellness. I'm Dr. Nathan Goodyear, and enjoy our future podcasts at Practicing with Dr. Goodyear.